So I thought I'd better put one of my videos in, and I've never ever used a 3D printer for my patients. I hope to do some dentures, but this is how I think it should be used. I used to use a Ceric blue cam and the milling machine, and you could do one restoration at a time, and it was great, but it was one restoration at a time. With the improvements with 3D printing, you can do a lot more restorations. They can print them all at the same time. So suddenly that opens up a lot more avenues and makes your workflow a lot better. So I thought, oh, what can I show? Well, I can just show what I did with my Ceric to a point. And I hope you find it interesting. The first bit's really interesting. I think I'm going to add the text below it. Okay, the reason I put this in is because this was developed by a dentist working on their own, doing what they thought was right. Now, when it comes to minimally invasive dentistry, I think I was practicing it, and but using my Ceric machine. The problem with I think the next slide just shows someone who was really against what she did, but actually it's now been taken over by all over the world, this idea that she had, and then she had the experience, and then people started researching it, and that's what happens a lot. We do stuff in practice that you would do for yourself or your family, and to be fair, we should do more of that. So I've retired, so let me just show you some of the stuff that I did. So we all did art. As soon as comprimers come out, we started using them rather than using amalgam in children. And bonding agents have improved all the time, but moisture control with kids is tricky. So anyway, I did art for sure. I never did a whole crown, I have to say. I did lots of Marylands. And this is what I used to call these natural bridges. When adhesives came in, you'd have these kind of classic cases whereby the lower anterior teeth would get loose, and then I'd just take them out, cut the root off, and glue them back in again off one tooth. And why off one tooth? Well, because they work off one, not two. And this is just, so the slides are not in great order, but this is showing kind of what I did. Now, this isn't pretty by any stretch, and but the woman didn't want to have a denture, and she said, could I stick the tooth in for her, which I did, and then she helped with a calculus splint. And so I did one, and when the other central incisor got loose, I said, well, I'll take out, as I said before, take out the remaining lower anterior teeth and make it a four-tooth partial, lower partial. And she didn't want that, so she asked if I could stick in another one, take it out and stick it back in again, which is what I did. However, that one didn't work as well. She fell out, she lost it. And then so she asked if I would do, as you could see, which is what I did, do a Maryland. And the problem with the Maryland is, obviously it stays in a bit better, but it doesn't pick up, her habit of 60 fags a day. And so it just stands out a little bit more. It doesn't look at all natural. And yeah, the basis of this was, I didn't have much of a support when I'd come out of university. I more or less worked on my own for like 2.5 years. And anyway, and that's not why I ended up in front of the GDC. That was something to do with the premises. But I had an interesting time at the GDC. And so I also worked at a private practice but didn't earn any money. And so I then went to an NHS practice. And, I've always supported the health service when I can. And this is the kind of thing I would do, is I did lots of these bridges. But this was the first one. And what had happened was that the previous dentist had made one with 3 wings, as we were told to. And the patient kept coming in every other week, having to have it re-cemented. And now, clearly her mum wasn't happy, she wasn't happy, and I wasn't happy. And I said, well, I think it'll work better if I take one of the wings off and just glue it to the one tooth. And she was not happy at all. She was crying. I remember her crying and shouting at her mum that she was going to sue me, which wasn't great, having just come from the GDC. Anyway, it lasted over 30 years. Until I retired, I used to still see her and her children. And it's not perfect, but it's good enough. And it was good enough for her. Nobody knows that she's got a missing tooth. And it wasn't until like 15 years later that I realised she still had half the tooth there, and she still does. So yeah, as I say, these are slides that I made just to talk about things to the FDs. And yeah, I've always been interested in IT, which is why I started doing this when I retired. I thought I'll make some videos about prevention. Yeah, so don't do as much windsurfing as I'd like to. Anyway, this was my one and only, let's see if it'll play. Yeah, my one and only testimonial. Maybe I should have done more of them. If you use my app, then you could. Anyway, this is sort of a typical type of thing that I would do. I was never great at doing composites. Had some, well, I replaced all the composites a previous dentist had done back in the day, and he asked for amalgam back. I mean, composites have improved an awful lot, but they're not a patch on these Cerex, as I used to do, mainly with Lava Ultimate, these hybrid stuff. And I'm pretty sure that the 3D printing materials now are far better than any composite, and you can do a lot more of them. Anyway, so when the preparation would be the same, and this is all scanning, you'll see pictures that look a little bit odd. I mean, and clearly I'm just doing these really quickly. I never thought people would look at them. Yeah, you see some spray. So I had a blue cam, which is the Ceric system back then. It just taken over from what was a red cam. And so when around this time, I went to the States, 2015, and that was I think it was the 25th anniversary of scanning in dentistry. So it's not new. Anyway, this all I would do is I'd remove most of the glass ionomer, and when it got near to the actual, the pulp, not the pulp, but just the tissue, I'd remove the rest with a ultrasonic, and that way it is minimal invasive. And then, having done quite a few of these, they glue in, so you just need to smooth the edges and glue them on, and that's what I did. And this is another one. So this is sort of classic, where a large restoration and eventually one of the cusps comes off. This time, big time. You can see the lingual aspect's really quite thin, so that's why I did took it over the occlusal ledge. And I always used to finish everything super gingerly when I could, because it's easy to keep clean and see what's going on. And we now know if there was a defect, you'd put a little bit of SDF on it, wouldn't you? And with a black margin, just like with the old crowns we used to make. And this is just showing, they're aesthetic, aren't they? So this was an onlay, and I think it was a really deep Carious restoration in like a 16-year-old. And so you can see a left part of the glass ionomer at the base. You very rarely get secondary decay under a glass ionomer, and so this is really like a sandwich technique that we were taught to do them, but really difficult to do. Well, it's certainly in my hands. And so this is another. So this is more common. I used to get quite a few of these where on premolar teeth where they'd lose one cusp. And I would just generally, well, you can see the amount of the cusp that was left. I would do cusp coverage, as you would say, but hang on to as much tissue as I could. And this is just one. This is just again, this was a young girl who, surprisingly enough, wasn't happy with this particular tooth. I have no idea what was going on with this tooth, but it just came through like that. Maybe it was a Turner tooth. I've never ever seen one, so maybe that was what it was. But anyway, so I kind of just smoothed it down a little bit, and so I think you call that a laminate. And it doesn't look like it's a great fit, but actually I think it's all right when you see the actual shape of the root surface itself. And again, it's still more or less super gingival. So whilst here it doesn't look great, when it's in her mouth, when she smiles, it looked fine. She was perfectly happy with it. And she'll keep it clean, everything's super gingival. At least you know what's going on. This is a couple of others that I tried, and you were always told about lower anterior crowns was don't do them. Well, with this material you can. And so I know it's not a great crown. You got a few dark triangles there. However, again, it's a lower incisor. It just hides the gap, which is what she was worried about. And the software's improved massively now, and the materials is better as well. So you can blend these things in. There's some really clever products out there. There's a 3D printer that can do lots of different colours for dentures. It'll be doing it for crowns. So the way that the printing's working for crowns, soon you'll be able to do all kinds of clever stuff. This was a patient, again, I remember the guy's name because he was a smith, and he was under, I think he was about 16, 17, with a massive palatal erosion from a Coca-Cola habit, not the other type. And I thought, right, well, I'll just try and see what we can do here. So I did Emax crowns as well, but you had to put them in the furnace. So, they sort of come out from the milling machine blue, and then you put them in the furnace and they come out white, and you can stain them. And I did quite a lot of them, but to be honest, I much preferred using the Lava Ultimate. I also think it's a better material because it sort of wears at the same rate as teeth, and this was borne out. I do think the way with both, all I did was scan what was left of the tooth. I didn't prep them at all. And you can see that I made a mistake on the left. I should have carried the more to the incisive edge. But actually, the one on the left is the Emax, and actually did chip, whereas there was never a problem with the Lava Ultimate. So that's made by 3M. I'm not sure if they still do it. There's a whole different issue going on about them that happened in the States, where there was a problem being produced because they were having some failures. And the failures were because the dentists were fitting them incorrectly. It was nuts. Anyway, this is, I think this is a root filling that I did probably, and tooth broke. I very rarely crowned root filled teeth until they'd had it for like 6 months, because that way I could be reasonably confident that they were successful. And that's one thing. My root fillings, in the end, the equipment that we have made them so much easier, and I hardly had any failures compared to back in the day when you were using hand files with a butterfly thing. It's just so much easier. It's a crime that we don't do more, but there's lots of reasons for that. Anyway, so you can see this is really quite subgingival. But as long as it's dry when you apply the adhesive, then it's dry enough, and these stay in really well. So this isn't a good example, but I had quite a lot where I used to call them an inlay-onlay, I think, because I'd use the access cavity and glue into the access cavity, if you can imagine. And this wasn't like that. This is slightly different. But they worked really well. This is just a veneer. So this patient didn't like the central, surprisingly. And yeah, I suppose I could have done a composite veneer, but I was never great with composite. So we did just did the 3M Ceric, and she was perfectly happy with it. I mean, it looks reasonable. Again, you can see just the powder from when I've been spraying it before. And it was as a laminate as I took it over the incisive edge, because the incisive edge was less than what is a crown on the left tooth on the left. And so I know it's a crown because I did it myself about 25 years before. It was Procera, and I only did a few of them, but you can see there's been gingival recession, but the fit's very good. She just got wear on the root. Oh yes, so she needs a gingival veneer then, doesn't it? No, she doesn't. Anyway, that's that. And she was really pleased. This is, again, going back to, I did work for about a year in a private practice, and he was head of the Pankey Institute, and he had a lab in Bristol that a lot of the work from the dental school used to go to. And I used to go there. I wasn't that busy, and I was not that confident about some of my work. And I'd take it up there, get it cast up, and have a chat with the lab technician. And then I realised, actually, I'm not as bad as I thought I was. In fact, I'm a good average. so what we often see, Instagram's new, but and there's an awful lot of stuff posted on Instagram, which is there the following day, and we all know that they then start to fail. And that's what's so good about 3D printing, is that for these composite veneers, instead of using composite now, we can print ceramic, or like 70% ceramic. So they're not going to pick up the staining, and it'd be a lot quicker to do. It's some of the things that are coming out are really brilliant. But this was a temporary bridge, and it was made, on the CEREC system. The blocks that you use are a lot bigger, surprisingly enough, because they're a bridge, and because of that, they were made out of acrylic. So what you're looking at the bottom is, it's clearly not a denture, although it actually looks a bit like a denture. But that's what I did all in one visit, and my nurse who still sees the patient in the supermarket. So this has lasted over 10 years, this temporary bridge, and it's far better than a denture. And there's no way on earth this lady could have implant work done. We have to think of other options for everybody else, and often reaching to do an implant is that should be the last thing you should be going for. And so you tried some desperate stuff. I think I did have an electrosurgery unit, but clearly I didn't use it here. And so as you can see from the picture of the crown, I put a little, I had a go at making posts within the material. Actually, they didn't work. It might have helped locate it as it was being placed, and that probably as much as it did. But as I said before, the one on the bottom left, that's a failure of a CEREC, in that I didn't overlay the cusp, and then after that, I think I probably did most of them. I'd always overlay the cusp, and generally on the molar, and the shades were a lot better. You couldn't tell really. You want to keep everything super gingival if you can. And this is just a case that I did. What would you do with this one? Right. To be honest, the best thing would have been to take it out and do a little Maryland. However, I think if I took out the lateral, the root, because I wouldn't ever find the canal to do a root filling, I would probably have destroyed the central with my fantastic extraction technique. So in the end, I think I must have done a little bit, but I scanned the tooth and put a crown on it, and I think it then really highlighted how awful the other tooth looked. You could see that was all filling. But you can imagine you're pretty anxious about doing a crown on this, and I hadn't done this previous work. I'm sure I've done something similar in the past, but we were struggling. Anyway, she wanted that replaced, and I did replace it now, I remember. And so she had two. So there she had these two crowns, the lateral, which is glued onto nothing, and then the central that looks more like a tooth. And it looks, a ladle view and a label view. I put that on there. But I always said to these things, when I did these things, is that this is minimal stuff, minimal dentistry. If it fails, we can go back to what the other options are, the traditional options are. And so this is what happened, is I got a phone call saying that the tooth's broken, the front tooth's broken. I thought, this isn't going to be pleasant, because she wants to hang on to her teeth. But it wasn't the ones that I did. That was the daft thing. It was the other one. And so you can see from the X-ray, I'm not saying this is perfect treatment, and there wasn't much of the tooth left. But so I put the time on the slide. So an hour later, she's got the crown in place and she's going. You can see the powder from the blue cam, and she's perfectly happy with it, right? And I'd say that it's perfectly happy. It's not the best treatment in the world, but she was really, really pleased with it. And one day she didn't turn up, and I rung up, and her son replied and said that she passed on. And I said, well, I've got these pictures of your mum's teeth. Can I use them in a talk? And he says, oh yeah. He said his mum would have been really pleased, because she was really proud that she didn't have dentures when she died. And she was really pleased with the treatment that she had. And this is her. I could never put the chair back. She had terrible problems with her spine. real difficulty. She used to see the hygienist every 3 months. I think in the end, probably the crowns were actually glued to one another, but she could get she couldn't get a TP through. Her manual dexterity was really poor, but she managed to hang on to her teeth with her and the hygienist, doing as best they could. And that's what it's all about. And this is, I don't know how, but yeah, I was talking to the FD, so I was showing a picture of me saying that, we need to maintain what we have, and it'll last a long time. Actually, the Volkswagen was forever breaking down, but everybody says they're great. And I've got a proper van now, but I do miss that one. Yeah, so I always put people on a plan, and to see the hygienist regularly, oral hygiene coach and all that. Anyway, I hope you found that useful. But the other stuff, there's I'm trying to remember the chap's name now. I know I put his videos down there.